Good evening, everyone. How are you all? Welcome to First Aid AMC MCQ again. So we're getting some back-to-back classes, right? It might be a little stressful for many of you, but again, it's really good and appreciated that you guys are joining the session. So we are going to do the cardiology question solve today. And this is also a part of our 2 weeks free session. And as we move towards the free 2-week session, we are actually now at the end of the 2-week session. We have only another class left, which is going to happen on 15th of July, which is just this Wednesday, right? Sorry, this Friday, not Wednesday. So this Friday, Dr. Rabia is going to take a question solve class as well, but that is mainly focusing on some recent sample question. I hope that you guys will enjoy the session as well. So tonight is mainly focusing on cardiology, the theory that you have learned that we are going to use today to solve some question. And you will find out that how easy it becomes if you know the theory well. So let's start. You've got your first question, who is a 17-year-old man was running a race and suddenly collapses on the floor. So sudden collapse means syncopal attack. It's a 17-year-old. Luckily, someone was there and performed CPR as patient did not have a palpable pulse and resuscitated him. Upon arrival to the ED, it is revealed that his father died at an early age. So that's very important finding. He is now alert, asymptomatic, ECG non-eventful, and he is anxious to go to home. What would you do next? Send him home, arrange an outpatient consult with a cardiologist, send him home, admit, refer to cardiologist team, outpatient echo, or you want to do a stress echo now. So the options are like this in the exam, because you will be confused, like which one you are going to do next. Am I going to do an outpatient echo? Am I going to do a stress echo now? Or should I just admit the patient first? The thing is that you are in the emergency department and this patient has got something related to heart. So you can't just send the patient home given that he had a collapse or syncopal attack and it was so severe that he needed resuscitation. On the top of that, he had a sudden cardiac death in the family and very early age. So these sort of things are important because that's actually showing that it is a very severe thing. You can't just send the patient home without finding that what actually happened today. So sending home is not your option. Now, are you going to admit the patient or you just want to do an outpatient echo? Or you can do a stress echo right now. The thing is that this stress echo, the decision of D and E should come from a cardiologist, not from the ED department. So you have to admit the patient and refer the patient for a cardiologist consult. That's your next step. Cardiologist will come and decide that what they want to do next. Okay, so that's important. I can see that many of you has said that it is C, so that's very good. So what is your differential diagnosis if someone has got sudden cardiac death history and now having syncopal attack? What is your two most important DD? DCM, SVT. SVT does not go through the family, so not SVT. DCM, dilated cardiomyopathy, no. What kind of cardiomyopathy? Yes, Savita, Dr. Kanishka, yes, Hukam. So HOCM is one of our most important DD because it can run in the family. It can cause sudden cardiac death in the family. And also patient can present to you with a syncopal or collapse like this. What else can it be? There is another condition in which patient might be younger like that, can have family history, can have syncopal attack. So what could be the other one? No, it is called prolonged QT syndrome. So prolonged QT syndrome also runs through the family, and that can also have a similar kind of presentation. Now, just by the stem, how you can rule that out? What is given in your stem that rules that out? Yes, Dr. Dillon. Right, so normal ECG, right? So if there is normal ECG, it cannot be a prolonged QT syndrome. So that's how we know that it's not prolonged QT, but most likely it's a HOOCM. So for HOOCM or whatever it is, we need to first admit the patient. Okay, good. See that I'm doing your brain a storm today, so I'll be asking a lot of questions. A young athlete presents with a history of sudden syncope and dyspnea. ECG shows left ventricular hypertrophy. Patient's father had sudden death at very young age. What is your initial treatment? So the diagnosis means that left ventricular hypertrophy, can we get it in a condition? Yes, we can get it in HOOCM also. Remember that ECG can give you left ventricular hypertrophy. So in this patient, again, the similar kind of history, but they are now asking for initial treatment. So now think about, we just had this class yesterday. So HOCM, what kind of heart failure it causes? Diastolic heart failure, good. So in diastolic heart failure, what is our choice of treatment? Yes, any of the calcium channel blocker or beta blocker. Now, we can see we have verapamil, which is a calcium channel blocker. There is no beta blocker here, so that's fine. So we can choose the verapamil in here as our initial treatment. Okay. Now, sometimes in between beta blocker and calcium channel blocker, if you need to choose between that two, always choose beta blocker because that's usually the best treatment for heart. So sometimes in the option you might get both, and then you will be confused which one to pick. So always try to pick the beta blocker first. Okay. So we already discussed about HOOCM, so we are not going to discuss it again. So as you can see, the treatment is beta blocker, calcium channel blocker. And we tend to avoid digoxin, diuretics, vasodilators, etc. Next, the same question. I will show you how one particular question comes in different way in the exam. A young girl, 15-year-old, collapsed at exercise. Her father had HOOCM. After ECG and echo, you found no abnormality. What is your next step? Halter, stress echo, repeat echo now, or repeat echo after 3 years. Yes, remember we told yesterday that if you get resting echo normal, but still you are suspicious about HOOCM, then your next step will be a stress echo now. You can't, doing a resting echo again doesn't matter. It will become normal. But repeating echo after 3 years, it's also not good because patient might die if you don't do anything about this. Okay, so a stress echo will be our next step. A 9-year-old was running and playing football, suddenly collapsed on the floor, presented to the ED, revealed that his father died at the age of 28. He is alert, asymptomatic. What would you do next? You want to do a Holter monitoring, a stress echo, repeat echo after 3 years, ECG, or echocardiogram now. ECG, right? See that, guys, you guys are actually understanding what I am trying to show you. Because we have seen in our previous questions also that they have done ECG in every patient, right? So ECG will be our next step in that patient. And then we will do a resting echo, and then we can do a stress echo. Moving on from HOCM, a 16-year-old male who presents with ejection systolic murmur in second left intercostal space. Which of the following is likely to be the diagnosis? Now, this is a tricky one. We discussed a little bit about murmur yesterday, if you can remember it, but we haven't discussed the pediatric CVS yet with you guys because that's a part of our pediatric class. So atrial septal defect So we have got ASD with aortic stenosis, ASD with mitral stenosis, ASD with pulmonary hypertension, and ASD with aortic regurgitation. Now, if you remember that this is your sternum, and we have got our intercostal space, and that's the second intercostal space, third, fourth, fifth. So this patient has got second left intercostal space, so over here, right? So this is your left, this is your right. So this patient has got murmur on the second left. In the second left, which murmur you get? Pulmonary murmur. Remember, right? Because your pulmonary artery comes like this. So it goes like this. So that's why you get pulmonary murmur in your second left intercostal space. Just by remembering that, you can rule out all other cases like aortic stenosis. You get it on the right second intercostal space. So it's out. Mitral stenosis, you get it on the apex. That means left fifth intercostal space. Aortic regurgitation, you get a murmur where at the left fourth intercostal space. So you can easily, you don't need to even remember any of this. You just need to remember that pulmonary murmur, most likely we get it in the left second intercostal space. Just by that, you can, even if you are not sure, you can at least say, or at least click on this C option in the exam that most likely this might be the case. Now, if you want an explanation about that, so what happens in atrial septal defect? So that means there is a septal defect in the intra-atrial septum. So in between two atrium, there is a division, which is the septum. Now, if somehow this septum has got a hole or easily like the blood can go in and out in between two atrium. So that is what we call as atrial septal defect. So there is a defect or a hole in the septum. So normally what happens, your left heart has got more pressure. So obviously fluid always go from high pressure to low pressure area. So fluid will go from left heart to right heart through this defect. Now what's happening is that there is more and more blood coming to the right heart now. Then the blood will go to the right ventricle, and from right ventricle through the pulmonary artery, it will go to the lungs. So what is happening that all the bloods which is coming to the right ventricle, now it needs to go, it will obviously go to the pulmonary artery, and it will cause increased pulmonary artery pressure. And that is what we call as pulmonary hypertension. So that's the pathophysiology, that how a ASD patient can end up having a pulmonary hypertension. Okay? Clear, guys? And if we look at the ASD and VSD murmur, you will find out that atrial septal defect, it is the second most common cardiac defect in children. And even in actual septal defect, you get this ejection systolic murmur along the left mid to upper sternal border. And it is because of increased pulmonary flow. Okay, so ejection systolic murmur in the left mid to upper sternal border. So upper sternal border means that first, second, third, those intercostal space, you will get this murmur mainly. If you look at the ventricular septal defect, which is the most common cardiac defect in children, they get a murmur which we call as pansystolic murmur, but it is actually at the lower part of the sternal ace. Okay. So VSD is the most common congenital heart lesion, and you get a harsh pansystolic murmur at the left lower sternal border. So left lower sternal border, if you get a murmur, then you think about ventricular septal defect. All good? Any question with this ASD, VSD? Did you guys understand how we get ASD with pulmonary hypertension and how the murmur happening? Yes? Good. Next, a young guy, while playing cricket, suddenly had syncopal attack without any convulsive feature. Soon he spontaneously recovered and started fielding, continue playing rest of the game. What was the cause? So sudden syncope and sudden recovery. Now we haven't discussed a lot about syncope, right? So we'll go through it a little bit now. So is it a vasovagal syncope, cardiac syncope, epilepsy, neurogenic syncope, postural hypotension? Anyone who can answer this? We will discuss this one because I think like we haven't discussed much about syncopal attack in our class. So vasovagal syncope is the most likely answer from many of you. And some of you are saying cardiogenic syncope. Dr. Dhilan, why do you think that this is a cardiac syncope? You can unmute yourself if you want. Good. So because there is no vasovagal symptom, right? Very good. Now, let's discuss a little bit about syncope. So syncope means loss of consciousness, and which actually they are saying that sudden collapse. That's loss of consciousness, and there is a fancy name given as syncope. So syncope, usually we think about cardiac syncope or cardiogenic syncope. We have neurogenic syncope, and then there are others. In the others, there are a lot of causes. One of them is vasovagal syncope. Then you have postural hypotension, you have cuff syncope, you have micturition syncope. A lot of syncope are there. The main difference between cardiac syncope and vasovagal syncope is that cardiac syncope happens very suddenly without any prodromal feature, like there will be no headache, blurry vision, no sweating, no sleep, no speech problem, no vision problem. So there will be no prodromal feature, and patient will not even know that they are going to fall. So the sudden loss of consciousness and sudden recovery without any confusion or drowsiness afterwards, that is what we will call as cardiac syncope. So this patient actually got sudden syncope and sudden recovery. So that's cardiac syncope in this patient. Whereas if it was a vasovagal syncope, the patient would have some symptoms which we call prodromal symptom. And this patient actually know that they are going to fall because they get these symptoms like they get blurry vision, they get sweaty, they get trembling, sometimes even they get headache. Okay, so lots of vagal symptoms will be there, and that means a gradual loss of consciousness, and then they will also recover gradually. So there will be confusion and drowsiness afterwards. Why it is not epilepsy? Because there is no convulsive feature in here. So epilepsy is out. How about neurogenic syncope? Neurogenic syncope also goes suddenly. That means patient also have a syncopal attack suddenly, but it takes a little bit more time to get the recovery. Okay. And in neurogenic syncope, patient will give you some features of neurological deficit, like patient might have convulsive feature, patient might have weakness, loss of sensation. So some neurological feature will be there in that case. How about postural hypotension? Postural hypotension or orthostatic hypotension, it is a condition in which patient's blood pressure drops when they change their position from lying to sitting or sitting to a standing position. So let's say when you wake up from your bed in the morning, so what you are doing, you are changing your position from sitting to standing. And at that time, there can have a sudden drop of blood pressure. And the patient can feel dizzy at that time. And that is what we call as postural hypotension. So with change of position, if someone gets dizziness, that's postural hypotension. This patient has not have anything like that. So you can also forget about it. So that's how we differentiate between each of the syncope. Is this clear for everyone? So we have cardiac syncope, neurogenic syncope, vasovagal syncope. These are the three most common ones. A 45-year-old male presented to the emergency department with left-sided chest pain radiating to the left arm and jaw. There is no ECG changes. Troponin is negative 4 hours since onset of the chest pain. He has been on sildenafil for erectile dysfunction, metformin for type 2 diabetes, ramipril for hypertension. What would be the most appropriate next treatment? So obviously this patient has got chest pain, sound like it's a cardiac chest pain. So what you are going to do next? There is no ECG changes, troponin also negative. So you are not sure that is it a MI or was it just an unstable angina. So you want to give nitrate, heparin, morphine, beta blocker, paracetamol. Remember the monotherapy for any acute coronary syndrome? So why it is contraindicated, Dr. Hussain? The nitrate. So what is the reason that why we can't give nitrate in this patient? Yes, because patient is on sildenafil, right? So a patient who is on sildenafil, we can't give nitrate to that patient because this can cause a very severe hypotension in that patient. So we don't give sildenafil in a patient who is on nitrate. So the nitrate is not your choice in this case. Paracetamol has nothing to do with cardiac chest pain. Beta blocker, not a initial management. It will come into the management later on, but not initial management. Now, between heparin and morphine, remember one thing. If you are not sure that it is a unstable angina or is it a is it like a what we call it non-ST elevated MI? So if you're not sure between the two, and if you don't get troponin positive, there is no need to start with heparin immediately. Okay, and again, like this patient actually will be on heparin later on, most likely, when we would do the troponin again after a few hours. But in this case, the first thing that we should do is going for a morphine first. Okay, because morphine is going to give the pain relief in this patient. So the best would be giving a morphine at the moment. Because if you would get some ECG changes like ST depression, T wave inversion, then at least we could think that it could be a myocardial infarction. So we are not sure at the moment because it might be totally normal. Like if there is no ECG change, if there is no troponin elevated, giving heparin doesn't make any difference. So only time we give heparin when your troponin will be elevated. That means in case of non-ST elevated MI. But for unstable angina, there is no indication to give heparin. Okay, so morphine will be your next choice in this case. So case by case, it will be different because if this patient was having some ECG changes at least, or if the troponin was elevated, then that patient would need a heparin immediately. Okay, so I know that this is a little bit tricky between B and C, but as they're asking for the next treatment, and they have already given enough information in the stem that this patient troponin and ECG is still negative, so we don't need to go for morphine at the moment. We don't need to go for heparin at the moment. So first we give the morphine, we do the repeat ECG and troponin again. If there is no changes, even after a repeat troponin, then are we going to give heparin to the patient? No, there is no need. Only time heparin comes to the treatment is when we get a patient with non-ST elevated MI. All right. Now this patient does not have silent MI because this patient having chest pain. Silent MI means having myocardial infarction but no pain. All right. Next question. A 72-year-old male presented with severe chest pain radiating to his back. So chest pain radiating to the back, what does it mean? On cardiac exam, you notice diastolic murmur. Chest X-ray shows widening of the mediastinum. ECG given. What is the most appropriate management for this patient? Now let's have a look at the ECG. So this was the ECG given. Now, we haven't discussed the ECG yet, but we will just be very quick so that you understand what we are discussing. So this is called chest lead. So V1, V2, V3, V4, V5, and V6. These are chest lead. And this is the isoelectric line that you can see. And that's your QRS. This is the ST wave. Now, obviously, if this ST wave should be here in a normal ECG. This patient has got ST depression because from the isoelectric line, it is obviously depressed. So lead V1 has got ST depression. V2 also has got ST depression. V3 also has got ST depression. If you look very carefully to V5 and V6, there is some ST elevation in here. Now, mainly you look at inferior lead, which is your lead 2, 3, and AVF. In lead 2, 3, AVF, if you look at the isoelectric line, this is your ST wave. See that how elevated the ST wave is. This is what we call as ST elevation. Same in lead 3, having ST elevation, and lead AVF having ST elevation. So these are your inferior lead, lead 2, 3 AVF. V1 to V6 are your anterior lead. Lead 1 and lead AVL, these are your high lateral lead. Lead 1 is fine, but lead AVL has got ST depression. So the main diagnosis in this case will be inferior AMI. And how about that ST depression? Normally, if you get inferior AMI, you get reciprocal ST depression in the anterolateral lead. So that's why you have got ST elevation in inferior lead, but you have got a reciprocal ST depression in anterior and lateral leads. Okay, so this patient also has got a ST elevated AMI. So chest pain radiating to the back, widening of mediastinum. That suggests this patient also got aortic dissection with myocardial infarction. So that's actually he has got. So what you want to do now, you want to give altiplase, which is a thrombolytic agent, aspirin and intravenous morphine. So they are asking the most appropriate, that means the definitive management, not the next. Give morphine, beta blocker, arrange for transesophageal echocardiogram, refer the patient to cardiology clinic, consider urgent MRI of the cervical and thoracic spine. So what do you want to do? This patient has got an aortic dissection. Are we going to thrombolize that patient? No. That's the absolute contraindication of thrombolysis because the patient will bleed to death. Right? This patient already bleeding in the aortic dissection area. So if you give altiplase, the patient will bleed more. So you don't give altiplase in that patient. Same, they are asking for a definitive management. Aspirin and morphine is not our definitive management. It can be our initial management, but not definitive. The definitive management for such condition would be obviously pain relief is our main thing. Beta blocker can be helpful for aortic dissection because remember I told you in aortic dissection patient, they get hypertension and beta blocker is usually our choice. In exam, you can also get patient having blood pressure of 160 by 100, something like that. So they would give you some information to help you decide. And obviously, we need to also arrange for a transesophageal echocardiogram. That's our definitive investigation to confirm aortic dissection. Are we going to refer the patient to cardiology clinic? Yes, but is this our main management? No, main management is C. Okay, because we are giving appropriate medication for aortic dissection. We are also trying to find out if this patient has got aortic dissection or not. How about MI? Now, between aortic dissection and MI, most likely the MI is happening because of aortic dissection. So you have to treat the underlying cause. That means you treat the aortic dissection, then patient blood flow to the heart will be restored. So that's why the main management or most appropriate management in here would be to at least start morphine for chest pain because this pain will be very severe. Beta blocker and transesophageal echocardiogram. Is this clear for everyone? So this is the widening of the mediastinum that you get in chest X-ray of aortic dissection. See how wide the mediastinum is. And this is the aortic dissection. So remember I told you if this is your left subclavian artery, if someone has got aortic dissection proximal to the left subclavian artery, that's type A, and distal to the left subclavian artery, that's type B dissection. There is a good discussion about aortic dissection in med bullets also. So I've given the link already. So please go through this in your own time. Next, an elderly man with multiple falls during the day, especially in the morning after waking up. So falls in the morning after waking up, ECG found left ventricular hypertrophy, multiple ventricular ectopic, orthostatic hypotension was also noted. How will you investigate this patient further? Repeated measure of blood pressure in supine and prone position, 24-hour ECG Holter, serum electrolyte. Let's say I am also saying that we want to do an echocardiogram. Let's say we want to do a stress ECG. So what do you want to do for this patient? Always remember, if you get a patient whose symptoms goes with postural hypotension and cardiac problem both, first of all, you have to confirm that if this patient has got any possibility of postural hypotension first. That means you have to confirm postural hypotension first between these two, because that's easy to do. You can do it in your own clinic. And this patient actually has got postural hypotension feature because he's getting fall during the daytime in the morning after waking up. And also you have got orthostatic hypotension. When you get one reading of orthostatic hypotension, your main thing that you need to do is to repeat that. And that repeat, how we do the repeat check, you do a repeat blood pressure in a standing and sitting position. But doing it on supine and prone position has nothing to do because patient is not changing position in that way. So that's why A is not your option. But if there was an option that repeat blood pressure in sitting and standing position, that will be our next investigation or next management. Now that this is not our option, then what else we can do? This patient has got some problem in the heart. So left ventricular hypertrophy, multiple ventricular ectopics. So the next thing we can do for this patient, are we going to do a 24-hour Holter, serum electrolyte, echocardiogram, stress ECG? The next thing should be done is a 24-hour ECG Holter, because always remember, Holter is the best test for a cardiac syncope or cardiac arrhythmia. This patient has got ventricular ectopic. We don't know that this patient might have got some other arrhythmia during other time of the day. So if we can check it as a 24-hour rhythm check, then we will be able to rule out any other arrhythmia which can lead to this fall. Like this patient can have heart block. This patient can have him like a severe block of their heart rate. Okay, so we need to find that out. So if you think that a patient has got multiple fall or syncope, and the main reason is cardiac arrhythmia, then the most important thing that you do is 24-hour Holter monitoring. After Holter monitoring, then you can do an echocardiogram to see that if the patient's heart is doing fine. Echo is mainly to find out the valve lesion and also to find out any other abnormality, like if the ventricular wall is not moving properly, which we call regional wall motion abnormality, which can suggest myocardial infarction also. Or sometimes echo can also show that if the patient having heart failure. So those are the reasons why we can do a echocardiogram, but echo would not be our first choice. Our first choice is to find out any other dormant arrhythmia which can cause this fall. Okay. So the basic thing is that if you think that a patient has got cardiac arrhythmia or because of cardiac issue, patient is getting syncopal attack, we do a ECG Holter. That means 24-hour Holter monitor. See this one, that loss of consciousness, if it's a sudden onset, it can be cardiac or neurologic. If the patient regain consciousness suddenly, that's cardiac. Gradually, that's neurologic. In case of sudden one, that means if it is a cardiac syncope, you do cardiac examination. If cardiac examination normal, then either it's ischemia or arrhythmia. To find that out, you do ECG, you do troponin, you do Holter or telemetry. So Holter and telemetry, these are more or less same kind of thing. This can give you the rhythm in the ECG for a 24-hour period. Okay. All good. Next, a young patient has been getting multiple lightheadedness, dizziness. His clinical features are normal. Chest X-ray ECG normal. Holter monitor shows ventricular ectopics. What will you do next? So the age of the patient is always important. So a young patient having lightheadedness and dizziness, clinical features normal, chest X-ray ECG normal. We have got Holter monitor which shows only ventricular ectopic. What will you do next? Reassure the patient. You're going to do exercise tolerance test, dobutamine induced echo or plain echo. Now, if you look at here, this is your JM, premature ventricular complex or ectopic ventricular beat. They are usually asymptomatic. 20% people are totally normal. Drugs that can cause this are digoxin. Look for some other evidence of ISD, pyrotoxicosis, left ventricular failure. Now look at here, if symptomatic, but otherwise well, with a normal chest X-ray and ECG, reassure the patient. So they have just made the question just from JM, right? If you look at the question now, you will see patient is symptomatic, otherwise well. So patient clinical features normal, chest X-ray, ECG normal. Normal chest X-ray and ECG reassure the patient. Okay, that means that if it is, especially if it is a young patient, if it's an elderly patient, I might want to do an echocardiogram. But if it's a younger patient, symptomatic, but everything is normal, chest X-ray, ECG normal, we don't need to do anything. It's normal to get ventricular ectopic. There is nothing you need to do. Just reassure the patient that it can happen. Okay. Now, obviously, if you get a patient that who is having very troublesome symptom, or if it is an elderly patient with multiple cardiovascular risk, then you can do echocardiogram. But otherwise, it's not needed. And for troublesome symptom, we can give beta blocker like atenolol or metoprolol. But before you start medication, you have to do an echocardiogram for the patient. Okay. Next. Now, this one is very confusing question. So don't get stressed a lot about this type of question because this just kills a lot of time. A patient is on amlodipine, amiodarone, furosemide, aspirin, had intermittent fall. ECG given looked like hyperkalemia. So now they are asking that which drug might be the cause of it. Is it amlodipine, furosemide, amlodipine, amiodarone, aspirin, amlodipine, aspirin, furosemide? Now, hyperkalemia. Now, the thing is that none of these medications actually give that much hyperkalemia. But again, it's question, we have to choose something. But the easiest way to do so is see the furosemide in here. This causes hypokalemia, if you remember. See the furosemide here, it also causes hypokalemia. So it's very unlikely that A and D will be our option. We have got two, amlodipine, amiodarone, aspirin, amlodipine. Between these two, amiodarone sometimes can increase potassium. The reason, I don't have any idea because there is no known reason that how amiodarone cause hyperkalemia, but just remember it. So amiodarone can cause it. Amlodipine, I don't know. Usually should not cause hyperkalemia. So because amiodarone can cause it, that's the only explanation that why we can choose B in this case. Okay, so not very convincing type of question, but time to time you will end up getting such question which will kill a lot of time. But if you look at this question, this will make sense. So you have got a patient who is taking multiple medication for hypertension and also patient having a lot of pain. Now patient coming to you with muscle weakness without any tenderness. They are asking that what is the medication which can cause muscle weakness without any tenderness? So ramipril hydrochlorothiazide, amiloride and ramipril, celecoxib and hydrochlorothiazide. Now remember one thing, thiazide diuretics, it causes hypokalemia. Same in here, it causes hypokalemia. Ramipril is a ACE inhibitor which causes hyperkalemia. So both of them should counteract each other and there should not be any problem. Same with celecoxib, it's a NSAID, it can cause increased potassium. So it should again counteract each other, so no problem. Now these two, amiloride, it's one of the medication falls under diuretics. It can increase the potassium. And obviously your ramipril also can increase the potassium. Okay, so that's the reason why we are thinking that most likely amiloride and ramipril is causing hyperkalemia because both of them can increase your potassium. And amiloride is actually just similar like spironolactone, which is a potassium sparing diuretic. So both ramipril can increase potassium, amiloride can increase potassium. Okay. So that's why B is our option. Okay, so let's take a 10-minute break now, and then we will go to our next question. All right. Any question, guys, so far? All good. So let's take a 10-minute break. Thank you. All right, everyone. So let's start again. So this is your next question. So you've got an ECG of an adult patient presented with chest pain, cardiac enzymes, and first ECG was normal, blood pressure 120/70. After 8 hours of observation, his BP goes down to 89/50. ECG showing supraventricular tachycardia with a heart rate of 150. What would you do? Adenosine, flecainate, atropine, synchronized cardioversion, defibrillation. Now, I know that we haven't discussed palpitation yet, but this is actually the cardiology question salvation. So we'll just go through this and we'll discuss the SVT along the way. So supraventricular tachycardia, it's one of the very common arrhythmia that happens in any patient, young or adult. And in supraventricular tachycardia, what actually happens that you know that this is the sinus node, then there is AV node, then there is Purkinje fibers, bundle of His, all of these electrical activities in your heart. Supraventricular tachycardia means that when arrhythmia originates from above ventricle, that means anywhere in the atrium. So that's supraventricular tachycardia, which gives arrhythmia or tachycardia in a patient. That's why heart rate is very high. When you get SVT in a patient, first thing that you need to know for management is that if the patient vitally stable or unstable. Vitally unstable means if blood pressure is less than 90/60, if patient has got confusion, if patient also having a severe symptom like severe chest pain or dyspnea or shortness of breath. Okay, so this means that patient is not vitally stable, especially if they are having less than 90/60 blood pressure. If patient is vitally stable, then management is usually conservative and then followed by medical management. The conservative or non-medical management starts with vasovagal, or you can say vagal stimulation. So that's usually your first management for vitally stable patient. The vagal stimulation, sorry guys, vagal stimulation you can do, either you can give carotid massage, you can also try Valsalva maneuver, you can try immersion of the face in cold water. Any of this stimulates the vagal nerve, and vagal nerve causes bradycardia. So that's how you can reduce the heart rate the patient having. So if this non-medical management does not resolve the problem, then medical management is, first line is adenosine. If adenosine does not help, then you have alternative of calcium channel blocker like verapamil. Okay, even after that, if still patient in SVT, then you can go for DC cardioversion. If patient is vitally unstable, then you don't do any of this non-medical or medical thing, you go directly to the DC cardioversion. DC cardioversion and synchronized cardioversion are same, which means that you give shock to the patient whenever you see R wave in the ECG. So you monitor the patient, and when you see R wave on the monitor, then you give a shock. That's called synchronized cardioversion. And then there is another term called defibrillation, which means you don't rely on R wave, you just give the shock. There is no relationship with R wave. And that's called desynchronized cardioversion. So synchronized cardioversion is usually the choice of shock in case of supraventricular tachycardia, atrial fibrillation, atrial flutter. Okay. So now this patient was initially vitally stable, but now patient obviously in cardiogenic shock. So your main management in here would be synchronized cardioversion. All right. Next, a patient was on digoxin, bisoprolol, thiazide diuretics, long-term history of hypertension and congestive heart failure, and AF. Stopped taking medication for 3 weeks while on vacation. So this patient is a heart failure patient taking all the heart failure medication, but stopped it. Now patient present to you with edema up to his knees, raised JVP with clear chest sound. Blood pressure is 145/90, pulse irregular. Obviously pulse will be irregular, patient has got AF, right? What would you do as an initial management of this patient? Commence furosemide, commence spironolactone, commence metoprolol, commence digoxin bisoprolol, commence all medication. Now this is a trick. Always remember, first thing only time you need to start with furosemide or diuretics if patient has got decompensated heart failure. And the decompensated heart failure, especially if the patient has got bibasilar crepitation, showing the patient has got pulmonary edema due to left heart failure, and patient is dyspneic. If patient having shortness of breath, if patient having bibasilar crepitation, that's decompensated heart failure. If patient has got those symptoms, that patient will need to start with furosemide. But our patient has got little bit of edema into the knees, raised JVP. This patient is going to get decompensation, but this patient, you can start with all medication now. So start with all medication, and then patient's heart failure will be managed in that way. Now, do we need to start the patient with spironolactone right now? No. First, we try with furosemide. Then if that doesn't help, then we can add spironolactone. How about just metoprolol? Patient is already on bisoprolol. That's a beta blocker. Why we will again give metoprolol, right? Because the patient having atrial fibrillation, you're already treating atrial fibrillation by giving, so either bisoprolol or metoprolol is same. So why we will give metoprolol now? Then do you want to give 2 beta blocker in this patient? No. So no need to give metoprolol because patient already on beta blocker. So the two thing is that if you have got a patient such as like this, and they are having clear chest sound, which suggests it's not pulmonary edema or their lungs are not edematous yet, then you can start with all medication. If patient having dyspnea or shortness of breath and bibasilar crepitation in the same question, then we should start with furosemide first to make sure that patient fluid overload gets managed first. Okay. All good? Now, this is also a kind of controversial question. So ECG was given. Now, if we could see the ECG, then it would be the best way, but we can't see the ECG. So ECG was given showing AM spike, QRS complex in all lips. And the most important is it is irregularly irregular. Heart rate is 150. Scenario gives patient with hypertension with a BP of 150/90. Patient was only taking atorvastatin. No chest pain, no other feature. What is your next management for this patient? So you want to give metoprolol, apixaban, warfarin, verapamil. Now remember one thing, that if you have got a patient with irregularly irregular heart rate or heart rhythm with heart rate 150, that's most likely atrial fibrillation. So for atrial fibrillation, if it is a rapid ventricular response, that means heart rate is more than 100, that is what we call as AF with RVR. In AF with RVR, you can actually control the heart rate. So how we control the heart rate in this patient? Now, to discuss a little bit about the atrial fibrillation. So atrial fibrillation patient, again, there will be chaotic rhythm originating from the atrium. So because of that, heart will beat irregularly and it will be like total chaos. In atrial fibrillation, again, you have to look that if the patient is stable or unstable. If it is a stable patient, then medical management is your first line treatment. If it's an unstable patient, then first thing that you do is DC cardioversion. In a stable patient, there are two things that you can do. One, you can control the rate. You can control the rhythm. If patient heart rate is high like that, then rate control will be our main choice. So the best rate controller are beta blocker. If not, then calcium channel blocker. Okay. If even after giving rate control medication, still patient in AF and stable, then you can give some anti-arrhythmic medication, which is a rhythm controller. You can either give sotalol, you can give flecainate, you can also try amiodarone. Okay, so either sotalol, flecainate, or amiodarone is your choice. Even after trying that, still patient in AF, then you have to go for DC cardioversion. Now, the management of AF is not finished until you check their risk of a stroke. And that risk of a stroke is very high in AF patient because when your heart beats chaotically like that, there is a possibility that left atrium can have increased turbulence of blood and it can end up forming clot over there. And that clot can dislodge and can form an emboli, and then it can go through your aorta into the carotid artery, and you can end up having a stroke. So that's why you have to make sure what is the risk of this patient to get a stroke by using a scoring system called CHATS score. That CHATS versus score will give you an idea that if you need to give any anticoagulation to this patient or not. Now we will have a question later on using this CHATS versus score, then we will discuss about it. Okay, so just keep the thought in your head for now. So coming back to this question, so this patient will need medical management because patient is stable. So you want to give metoprolol, apixaban, warfarin, or verapamil. So obviously we don't need to go for anticoagulant before we control the AF. So this is our last thing to think about, not the first thing. First thing is to control the heart rate. So this is a beta blocker, this is a calcium channel blocker. In between these two, we will always choose the beta blocker first. Okay. If a patient having AF with heart failure and the heart failure is controlled, like compensated heart failure, what is your choice of medication for AF? Guys, so controlled heart failure with AF, right now, you want to control the heart rate of that patient. How you are going to do that? Beta blocker. Remember that you should not give calcium channel blocker in a heart failure patient. The best management, even for AF with a controlled heart failure, is beta blocker. But if it is a decompensated heart failure with AF, then only you can think about giving digoxin. Because decompensated heart failure, you should not start beta blocker. Okay, so compensated heart failure with AF, our choice will be beta blocker. Decompensated heart failure, our choice will be digoxin. Next, a middle-aged man with a known hypertension started feeling dizziness and he feels his heart is racing. It occurred after running. So what we have found so far, a middle-aged man, hypertensive, feeling dizzy and heart racing, and occurred after running. There was also travel history few days ago. He is on irbesartan and hydrochlorothiazide. So this is a ARB, and then thiazide will control blood pressure. No mention of diabetes. BP was also good with no postural change. What is the most appropriate next investigation? CTPA, D-dimer, THAs, or troponin. So patient having racing of the heart, which means palpitation. Palpitation, feeling dizzy, and patient also having a travel history few days ago. What is your thinking in your head? Yes, pulmonary embolism. Travel history few days ago, that is actually a very important clue, because if patient has got a long long flight history or a travel history, and after travel now patient is started to get palpitation, feeling dizzy, that's something which we need to think about, that is it a case of pulmonary embolism or not. Because pulmonary embolism patient present similarly. They come to you with palpitation, sometimes chest pain, and they can get a dizziness as well. So when you think about pulmonary embolism, if they're asking for most appropriate next investigation, if your diagnosis is pulmonary embolism, your initial, your best, everything is CTPA. D-dimer is a non-specific investigation for pulmonary embolism. So it's not usually your choice of investigation most of the time. So in this patient, obviously, we would do a CTPA first. Patient does not have any chest pain, so doing a troponin doesn't make sense. THAs we will do, but this patient actually has got a very sudden onset of symptom. If it is a thyroid problem, it will be not just sudden, patient will have this for a long time, or at least for a couple of weeks. So sudden onset of dizziness, palpitation, after a travel history, we would think about something like pulmonary embolism. Okay, so CTPA, which is your CT pulmonary angiogram, is our choice. Now, I know that we haven't discussed pulmonary embolism yet. When we will do the respiratory system, then we will discuss about it. So the relationship between travel history and pulmonary embolism, very good question, Dr. Hussain. So sometimes during travel, what happens that it's a very common thing in here. So many of the patients will have a long flight, like 8 hours, 12 hours flight, and they will be totally sitting on the plane without moving at all. When you are immobile for a long time like this, you start to develop venous stasis in your lower leg. And when the blood does not flow, it tends to get clotted. So you will end up getting a clot in your deep vein in your leg. And that deep venous thrombosis will travel to your lung and it will cause the pulmonary embolism. Okay, so long travel history is always a #1 risk factor for DVT or pulmonary embolism. Yes, most appropriate or next, whatever it is, your initial, your best, everything is CTPA. Okay, unless patient is pregnant, then you can do a VQ scan. Now, we will not go into that. We will go into that, like we discuss a lot about P in our class. So pulmonary embolism we'll do a full discussion during our respiratory system. But remember that for pulmonary embolism, your next, your best, everything is CTPA. 60-year-old male with a 10-year history of hypertension, feeling dizzy, lightheadedness from this morning when he was doing exercise. So exercise-induced dizziness. Smoker, drinks 2 to 3 glasses of wine. Blood pressure is controlled. And there is some postural blood pressure. Currently on irbesartan thiazide diuretics and also aspirin. Symptoms lasted for about 2 hours. ECG was given showing SVT with a heart rate of 150 per minute. What is the cause of his presentation? Dehydration, ischemic heart disease, hypertension, alcoholic cardiomyopathy. Now remember one thing. Supraventricular tachycardia, sometimes the underlying cause can be totally normal, but in some cases, ischemic heart disease is one of the other causes as well. So if you get a patient who is 60-year-old with multiple risk factor of cardiovascular system, which means hypertension, and you have also got patient is a smoker. So all of this put this patient in a high risk of CVD. So for this kind of patient, we don't think twice. We don't just think that it is dehydration causing this. Our first thing is to rule out ischemic heart disease always. Okay, so because that is actually the most likely reason in a 60-year-old. But if this patient was a 30-year-old, I would rather choose dehydration because patient was doing exercise. Maybe due to the exercise, patient got dehydrated, and dehydration can also cause this kind of ECG changes. So it depends always on the age. If age is like above 50, multiple cardiovascular risk factor, we would always think about ischemic heart disease. If patient coming to you with sudden headache, sudden dizziness, especially exercise related. And ECG can show a lot of things, SVT, AF, but underlying cause can be a ischemic heart disease. Okay? Any question, guys, so far? You understanding me? Next. You have got a patient and you have done ECG, which showed bradycardia with a prolonged QT. Patient came with chest pain for 15 minutes and relieved by rest. Troponin normal, pulse normal, regular, BP normal, what to do next? So ECG with bradycardia and prolonged QT, patient had a chest pain lasted for 15 minutes, relieved by rest. You want to do a repeat troponin, echocardiogram, coronary angiography, repeat ECG. And let's say it's a 60-year-old male. Remember one thing, that if you have got an elderly or middle-aged patient who has got chest pain, which lasted more than 10 minutes, you can't rule out myocardial infarction until you do multiple serial ECG and troponin. So you have just done one ECG and one troponin. That doesn't mean that after a few hours, troponin will be normal. You can get like 1,000 troponin after a few hours. So your next thing, because they're asking what to do next, is to do a repeat ECG in this patient. Even the pain is relieved, still you have to follow the protocol. So repeat ECG, repeat troponin is your first thing that you do. And then later on, if that is normal, then you can think about doing echo, even sometimes Holter. Okay. Next, a woman on multiple drugs. One of them was digoxin. She presented with central abdominal pain and tenderness. Her pulse is irregular. Apart from CT abdomen, what is the most appropriate next investigation for her? Now, this is not directly related to cardiology, but you can say it's a complication of cardiac problem. So, irregular pulse, patient on digoxin, does it sound like any specific condition? No, atrial fibrillation, right? Because the patient can be on digoxin and pulse is irregular. That means patient is having atrial fibrillation, right? Now, remember we told that atrial fibrillation can cause clot or emboli. Now, one emboli can get blocked into your carotid artery and causing a stroke. Another emboli can come to your gut and can block the superior mesenteric artery. And if it blocks the superior mesenteric artery, you get a condition called mesenteric ischemia. In mesenteric ischemia, the patient usually is very elderly, above 60, get a central abdominal pain with parectal bleeding sometimes. So anytime if a AF patient presents with central abdominal pain and that patient is elderly, you should always consider checking for mesenteric ischemia, because that part of the gut is not getting enough blood supply and that can become totally non-viable. So the main thing that you do is to do a CT angiogram to confirm the diagnosis. Along with the CT angiogram, because they're actually doing a CT at the moment, but they're asking along with the CT angio, what is the most appropriate next investigation? Now remember one thing. So if there is a block in superior mesenteric artery, in this part of the gut, there will be ischemic necrosis and there will be production of lactic acid, right? And that's why if you check the serum lactate, that will be very high in this patient. So that's the only one thing that you can do in this patient, and that can be quite high as well. All right, so that's mesenteric ischemia. There is a good guideline in the Medscape for this. So if you want, you can go through it. And you can see that the patient usually comes to you with a central abdominal pain, sometimes watery and sometimes bloody diarrhea, sometimes even vomiting. And you can get localized central abdominal tenderness. The management for that condition is surgery. Next, a 23-year-old male comes for follow-up. His bilateral arm blood pressure is 140 to 160 by 100 to 110. So obviously, the patient's diastolic blood pressure is very high and systolic is also high. So it's a hypertensive patient. Occasional headache, rest of the physical exam and urine analysis is normal. Heart rate normal with mild left ventricular hypertrophy that can be due to the hypertension. Beta blocker hydrochlorothiazide captopril was used, but still BP is 150 by 100. What is this called? You have tried 3 medication, but still blood pressure is high. What is the name of it? Yes, Benish, very good. Refractory hypertension. So always remember, if you get a refractory hypertension in a young patient like this, you should think about a specific condition, which is what we call as renal artery stenosis. It is very common in this population, and one of the most important cause to rule out if you get a refractory hypertension is the renal artery stenosis. So your most appropriate or next appropriate step is to do a duplex ultrasound of the renal arteries. The others are not very important at the moment. So renal artery stenosis should be considered in patients. Now, they say that it's older than 50, but renal artery stenosis can happen in young population also. If that patient develop high blood pressure, have no family history of high blood pressure, and you have treated the patient with 3 or more different type of blood pressure medication, still patient having high blood pressure, think about renal artery stenosis. And then there is a guideline in here about the renal artery stenosis. Please go through the link and go through and just read it in your own time. Next, an elderly man taking digoxin and hydrochlorothiazide presents with palpitation. ECG was given. What is the cause of his problem? Now, this one you will not understand because we haven't discussed the ECG yet. So, only thing that I can say from the ECG, this patient is an elderly patient on digoxin, presenting with palpitation. And your options are digoxin toxicity, hypokalemia, hyperkalemia, right? It's very unlikely that they will give you a hypokalemia ECG in the exam. In hyperkalemia, you get like a tall peaked T wave. That means the T wave will be like this. Okay, so it will be very tall. So you can't see any of this here. So that's why it's not hyperkalemia, most likely also. But it is actually called digoxin toxicity ECG. In this ECG, first thing that you see in the lead 2, you can see that this is one R wave, this is one R wave, this is one R wave, this is R wave. And you can see that they are irregular. So this patient is on atrial fibrillation at the moment. Also, if you look at V4, V5, V6, you can see a ST depression. And that ST depression has a specific feature called reverse tick sign. It's like this, right? So reverse tick sign with the ST depression, especially in the chest lead, that also you can get in digoxin toxicity patient. So that was actually a digoxin toxicity ECG. Now we will discuss this in our ECG class, so don't get bothered about it right now. Moving on to the next question, a patient on many medication, metoprolol, digoxin, furosemide, ECG given, patient complains nausea, vomiting, abdominal pain. digoxin level was normal, what to do? And again, if in this ECG, there was some features which showed that this patient is having a digoxin toxicity. So let's say that ECG features showing digoxin toxicity, but your digoxin level is normal. And patient complain of nausea, vomiting, abdominal pain, which is the most common feature of digoxin toxicity. What do you want to do next? You want to cease digoxin, cease metoprolol, temporary pacemaker, angiogram, cease metoprolol, start verapamil. So the main thing that you have to do if you get a patient with digoxin toxicity feature, ECG showing digoxin toxicity feature, but level normal, still patient can have toxicity with a normal level. So your main thing is to cease digoxin in this patient. Now, two things, excuse me. We have a condition called WPW syndrome. So you have got a ECG of WPW syndrome. Now, what is WPW syndrome? In this condition, if you see that the electrical activity starts from SA node, then go to the AV node, and then to the whole ventricle, right? In the AV node, usually there is a AV nodal delay, and which is supposed to block any excessive heart rate coming from atrium going to the ventricle. But in WPW syndrome, what it will do is that there will be an accessory pathway between atrium and ventricle, which will bypass this AV node, which means that every excess heart rate your atrium is producing, it's going directly to the ventricle. So that is what we call as WPW syndrome. Now, the management of WPW syndrome is more or less same like SVT-AF. So if patient is vitally unstable, then DC cardioversion. If it's stable, then you have to reduce the heart rate. As you can see, the heart rate is 280. So in this patient, if you want to reduce heart rate, you can't give any medication which can block the AV nodal or which can block the AV node. So almost every rate limiting drug can block the AV node, like beta blocker, calcium channel blocker, adenosine, almost all of this, and also digoxin. So all the beta blocker, calcium channel blocker, adenosine, digoxin, these four, which you commonly use, they usually cannot be given in WPW syndrome because those can block the AV node and it can make it worse. The only medication that you can give in WPW syndrome is amiodarone or procainamide. Okay, so antiarrhythmic agents, only the drug that you can use. So that will be your answer in this case. So you can't give verapamil, adenosine, digoxin, nor even beta blockers. Okay, any question? Now, we normally don't use atropine for this kind of problem, like arrhythmia kind of thing. Atropine is usually given for heart block patients who are symptomatic, but not for usually this kind of tachycardia. Next question, a 65-year-old patient present with lightheadedness and palpitation. Examination was clinically normal. He is on perindopril, L-troxin, which is like a thyroid medication, verapamil, anti-diabetic medication. ECG shows first-degree heart block. What is the next most appropriate treatment? So this patient has got heart block. What you want to do about the medication? You want to increase the thyroid medication, stop verapamil, stop perindopril, add digoxin. The main thing is that if you get a patient with heart block, that means they are already got bradycardia. So you have to find out a drug which can reduce the heart rate and stop that one. So only one which can reduce heart rate in this patient is the verapamil. So stop this one. Okay. Perindopril has nothing to do with heart rate, so this is not your option. Digoxin can reduce heart rate, so you will not obviously add that. And increasing the L-troxin will have nothing to do with heart block. So when you get a heart block patient, find out the drug which can reduce heart rate and then stop it. You have got a patient who is a child with upper respiratory tract infection treated for infective endocarditis. Blood culture taken, treated with penicillin, but murmur is still present. What to do? The thing is that if you have got a patient with infective endocarditis, which is a vegetation or infection in your heart endocardium or heart valves, in that case, obviously, the main thing that you do is to do a blood culture. And after blood culture, you treat the patient with appropriate antibiotic like penicillin. Sometimes even you have to add gentamicin, flucloxacillin. Sometimes even patient might need vancomycin if in severe cases. That's not the issue. The issue is that if you have treated the patient appropriately, that patient murmur should not be there, which means that still patient might have infective endocarditis. So what you are going to do next? The next thing that you do is to repeat the blood culture again, or you want to do switch to meropenem, or you want to do echocardiogram, or you want to give antibiotic for 4 weeks with blood culture weekly. The best thing that you can do in this patient is to do a echocardiogram because blood culture is already taken and you have actually already started treatment with penicillin. You might not get anything by doing culture, and blood culture is not your most appropriate investigation for endocarditis. The most appropriate or best investigation is always an echocardiogram, and it can show the vegetations still in the heart or not. So if you want to see that why the murmur is still there, then the best thing that you can do is to do an echocardiogram. Okay. Next, a pregnant woman at 36 weeks of gestation presents with dyspnea and orthopnea. X-ray shows bibasilar effusion and cardiomegaly. And examination shows bibasilar crepitation. What is your next appropriate investigation in this patient? ECG, echo, D-dimer, CTPA. So what's your diagnosis? Dyspnea, orthopnea, bibasilar crepitation. Heart failure, guys, right? It's in front of you. Dyspnea, orthopnea. If you get orthopnea, you should think about heart failure immediately. So orthopnea with a cardiomegaly also. So why pulmonary embolism? And why D-dimer? Because D-dimer will be elevated in a pregnant patient. So remember one thing, D-dimer is almost never a choice of investigation in your exam. So don't think about D-dimer in exam. So what you want to do next if it's a heart failure patient? ECG, guys, right? Remember we talked about heart failure. So ECG will be your next appropriate investigation. So you have inserted pacemaker in a patient. Now coming to you with difficulty in breathing, with faint heart sound, saturation 96, patient is having hypotension with raised JVP, no ECG given. What is your investigation of choice? Now this we have discussed yesterday. You've got a patient who has got faint heart sound, hypotension, raised JVP. What is your diagnosis? And what is this triad called? Beck's triad, right? So where we get Beck's triad? Cardiac tamponade, right? Good, Dr. Benish. So for cardiac tamponade, what is your investigation of choice? If you want to find out massive pericardial effusion, the only way to get it is echocardiogram. Okay, good. See that now the theory is coming handy. A hypertensive and a diabetic patient presented with history of numbness, nausea, and sweating. He developed dizziness while urinating. Pulse is irregular and ECG shows atrial fibrillation. So, tricky question. Again, think that this patient is 65-year-old gentleman, hypertension, diabetes, history of numbness, nausea, and sweating, dizziness while urinating, irregular pulse with AF. What is your diagnosis? Myocardial infarction, micturition syncope, vasovagal syncope. Now, whatever it is, the patient developed dizziness, numbness, nausea, sweating. Nausea, sweating in a 65-year-old with multiple cardiovascular risk factor. You don't think about anything else. You think about myocardial infarction as your first diagnosis. So always think about the common thing. Don't think micturition syncope in this patient. It can be, we don't know it, but first thing that we think about is this the MI patient or not? An elderly woman brought after fall who is very confused and on warfarin, bruises on both thighs and buttocks. Troponin actually normal, but CK is very high. What is your diagnosis? Recent MI less than 12 hours, MI in 4 hours, rhabdomyolysis. Now, if it is MI, by 4 hours or 12 hours, troponin usually will be high, right? So A and B is very unlikely. What usually happens, many elderly patients they live alone in here, right? Totally alone, no one at home. And they get confused if they have a fall, and sometimes they can stay there confused on the ground for several hours, even days. And then someone will call ambulance, maybe neighbor, and then you will find out this patient has got a condition called rhabdomyolysis. So rhabdomyolysis, it's a condition where the muscle tissue break down, and usually happens after a fall and then for a prolonged immobility. The muscle tissue breakdown will release a particular content into the circulation called myoglobin. And this myoglobin sometimes can block the kidney, and it can cause acute renal failure in the patient. Patient also can get a dark reddish brown urine due to myoglobin so patient can have a hematuria kind of feature. If you do the kidney function test, especially if you do creatinine, urea, everything will be elevated. So you will get a renal failure. And most importantly, because it's a muscle breakdown, the CKMB will be really elevated in this patient. So let's give you a diagnosis. The important thing is that rhabdomyolysis can be life-threatening because it causes dehydration. Due to muscle breakdown, it causes hyperkalemia, hypocalcemia, and eventually cardiac arrest. So the main management is hydration. So if they ask that what is the management of this patient, give normal saline, IV fluid. That's the initial treatment for this patient. Next and last question for tonight. A patient on medications for hypertension, perindopril and indapamide, she feels dizzy when get out of the bed. And it's been happening for a while. She also had some falls. Blood pressure 160 by 100, has atrial fibrillation. What is your next investigation? So you've got a patient with antihypertensive medication, and she's having postural hypotension feature, like she feels dizzy when getting out of the bed. Blood pressure 160 by 100, has AF. What you want to do next? Echocardiogram, X-ray, Holter, 24-hour BP, repeat postural BP measurement. Remember, we just talked about it. If you get a patient with features of postural hypotension, you haven't actually measured the patient's blood pressure in a standing and sitting position yet. The first thing that you do is to do that. So you repeat the patient's postural BP measurement. That's the first thing, because maybe because of a lot of antihypertensive medication, patient getting hypovolemia, and that's the reason of having this dizziness or fall. So if you get a feature of postural hypotension, the first thing that you always do is to measure the blood pressure in sitting and standing position. It's not only one reading, you have to do multiple reading to confirm it. Okay? So that's actually all about cardiology question solvation for tonight. Do you guys have any question? So obviously this is actually last session with us, with me actually. So this is the last class of free 2-week session, which will be taken by me. The next one will be taken by Dr. Rabia on 15th. So I hope that actually that you liked our session for this 2 weeks. And obviously, like if you want to know anything about the course, you can ask me now, and I will just unmute you so that you can ask it. So if you want to unmute yourself and ask any question about the course, feel free to do so. And we will just go through the course detail again, because this is our last session with many of you. So as you can see that the course detail involved, the course is going to cover full theory session. So we just did one theory like cardiology. So such as like this, there will be pediatric session, obstetrics, gynae, in that way. We'll discuss 4-year sample question from 2018 to 22 with monthly update. And you get one class every week on monthly question solve. That question solve class will be your next class with Dr. Rabia. And you get this class every week. You get a software-based multiple mock test, and those are unlimited one. You have subjective mock test, month-wise mock test, and also full 150 question mock test, which are included in the course. You get a Q bank, you get access to the note until you pass, you get a recording with extended video access, and also you get CPD hours when you join our theory class. The duration of the course is for 5 months, and we take 3 days a week class, Sunday, Tuesday, Wednesday. This is our regular class. We are not taking the regular class in the free 2-week session, but once course starts, you will get class in according to this schedule. Class time is usually 2 hours, 7:30 to 9:30, sometimes 10 p.m. Sydney time. And we already discussed what we cover. I guess that you already have gone through all of it. And obviously we have extra classes on ECG, CT scan, X-ray, CTG, statistics, and fundoscopy, ABG. Right, so that's pretty much everything about the course. You can always go through the course detail in our Facebook group. And if you have any question, you can always ask it. The course admission will be open. We will keep it open until this July. So if you want to get admitted, this is the time, because once this 2-week session is over, then you will not get any more sessions with us, and we will just take classes along with the course. I can see that many of you are already enrolled in the session, and I mean that most of you who are here, you are already enrolled. So you will also get an orientation session with us once this 2-week session is over. I know that many of your software access is still pending. It's actually, we do it after 2-week session is over, then you will get full access. So after 2-week session is done, still you haven't got your access, please make sure you send me a message in my messenger that you are waiting for approval. Sometimes we can miss for a couple of people. So in that case, you just get back to us, okay? If you haven't made account in our software yet, then we already uploaded a video in your course group. Go through that, make an account, and that's the first step to get the access. Once you make an account, you send us a message that you made the account and you are waiting for approval. Then our IT team will be involved and approve your account, okay? So Dr. Amiri, so because it's a 5-month session, we started the course, I think on 3rd of July. So just maybe it will be like early December will be your last session. You will get all the PDF for every book that you need. But the 8th edition is still, we haven't got the PDF version of it. We are still waiting for it to come in the market. So because that's a copyright issue, we can't provide it to everyone. Okay, so until it comes in the market as a whole, like the 7th edition, you guys will just have to go with us, because we actually go through everything from JM 8th edition in the class. So you will have everything on your lecture note. Okay. All right, any question? All good then. So we'll stop it here tonight. Thank you everyone for joining these sessions. Have a good night.